Good afternoon, everyone. So today I'm going to talk about what we can learn from maternity improvement programmes implemented in the NHS in England since 2010. And I want to start with really what is the key finding from this work we've conducted, which is maternity improvement is undermined by deficits in accountability, in learning, and in programme design. And this translates into what I would describe as three gaps in the maternity improvement landscape in England more broadly. So firstly, we have an accountability gap, so insufficient accountability for how we're using the resources to stimulate improvement in maternity services. Second, we have a learning gap. So this is about our ability to accumulate learning from programs over time and to make reliable judgments about what works, what doesn't work, and the effectiveness of these programs. And thirdly, we have what I would describe as a policy program design gap. So this is really about is there alignment, or is there a connection between stated goals of policy, particularly at national level, and how these programs are actually designed and delivered in practice? So I'm going to go into some of the background as to how we identify these gaps through a scoping review that we've been leading at this institute. But the starting point for our story, or a good starting point, is that avoidable harm in NHS maternity services is actually a very long-standing problem. So we see this issue of recurring, very high-profile failures in patient safety and repeated organisational failures in maternity, stretching as far back as 2004, which was the period initially covered by the Morecambe Bay investigation. Underlying this, we have the issue of performance variation. So we know, for example, that around 40% of maternity services in England, possibly more than that now actually, are rated as either inadequate or requires improvement by Care Quality Commission, who are the regulator. In response to this, we see an explosion, a plethora of improvement initiatives. So strategies, programmes, and initiatives, all seeking to address slightly different aspects of safety challenges in maternity care. So what we set to do in our review was firstly to identify the large-scale maternity improvement initiatives that have been implemented since 2010, and second, to assess those programmes against selected features of quality. And we drew on a number of published standards and evidence bases to assess or to benchmark programmes, if you like. And we did this in three main areas. The first thing was around transparency of reporting. So are programmes described in sufficient detail? Are they specified well enough to facilitate their replication in different settings? And again, we drew on a published standard for description of complex interventions for this. We had a number of checklist items to support that. Second, we looked at evaluation in terms of its planning, its quality, and its design. So is the evaluation of maternity improvement set up in a way that allows us to accumulate learning in a systematic way about what works and what doesn't work? And thirdly, we looked at programme design. We looked at a number of different features here, but we focused on implementation support for maternity services. And we also considered inequalities, patient and public involvement, and the extent to which these programmes were based on sound evidence. Now to our findings. So firstly, maternity improvement is undermined by an accountability deficit linked to lack of transparency, particularly lack of transparency in reporting. And just to illustrate this point, of the 30 or so large-scale, mostly national maternity improvement programmes that we found that have been rolled out in England since 2010, unfortunately, we could only include half of them in our review for assessment. And the reason for that is that 15 out of our 30 programmes did not have a publicly available published evaluation report. So this really speaks to a fundamental gap in accountability. If these evaluations are not being published, if they're not in the public domain, then we don't have sufficient accountability, in my view, for how we're using our resources in maternity improvement and transparency of what works and what isn't working. For programmes that do have a published evaluation report, we found that transparency was broadly poor in terms of the quality of reporting. So we found completeness of reporting varied markedly between programmes. No programmes that we assessed described all of the checklist items in full from our adapted published standards that I mentioned earlier. And we found that a third of programmes provided no description at all for up to half of the checklist items. So we see this widespread poor transparency of reporting in maternity improvement. Next, maternity improvement is undermined by failure to learn through evaluation. So this speaks to the need to accumulate learning in a systematic fashion. And again, we see widespread weaknesses in evaluation planning, in quality and design. So to illustrate this, so first of all, we found that fewer than half of the programs we assessed had a prospective evaluation plan. In terms of quality, we found only 5 examples of effectiveness evaluations that had been published in peer-reviewed journals. And we also see this reliance on weak designs, so typically post hoc and low quality evaluation methods. And the recurring theme here is a really evaluation as an afterthought. So the failure to factor in or to plan for evaluation in advance, and we subsequently see quality deficits as a result, and subsequent failures to accumulate learning effectively. Thirdly, and finally, in terms of our findings, maternity improvement is undermined by gaps between policy and programme design. So this speaks to what I describe as a disconnect between the stated objectives of national policy and how improvement programmes in maternity are actually being designed and how they're being delivered in practice. And we found a number of examples of this and a number of programmes with programme design in maternity improvement. And I'll just share with you some of the key ones. So firstly, we see weak implementation support for challenged units. No examples of customization or enhancement of implementation support to support those units that are struggling most to improve. We see that most programs didn't involve women, birth partners, or families. So again, this disconnect between, we have this high-level objective to involve women and birth partners in the design of maternity improvement, but we see that that isn't actually happening in practice. So more than half of our programs didn't involve women at all, either in their design or their delivery. Almost half of the programs we assessed did not cite an evidence base for their interventions. And I know I don't have to work particularly hard with this audience to persuade you why that might not be a good thing. But sufficient to say that maternity improvement programs need to do a better job of basing their interventions explicitly on evidence, if only to persuade clinicians, for example, that this is a worthy use of their time. Finally, arguably, I would say probably the most striking finding from our review, no programme cited the reduction of healthcare inequalities as an explicit goal. So again, I think this is the most striking disconnect, if you like, between policy and practice. You have stated policy goals at national level around reducing inequalities between ethnic groups, between different socioeconomic groups, but we're finding this is not translated actually into practice and how these programmes are being designed. I want to close just by wrapping up with what I describe as 3 commitments to address these deficits in these three areas, so accountability, learning, and programme design, so that we can optimise maternity improvement programmes going forward. Firstly, we need to, as a system, commit to transparency and high reporting standards. So where evaluations of improvement initiatives and programmes are conducted, they need to be published, they need to be made available in the public domain, so that others across maternity care can draw conclusions about how we are using our resources to stimulate improvement. Where evaluations are published, we need to commit to high reporting standards. So we need, and there's lots of guidance available to support this, but we essentially need to commit to transparency in how we're reporting improvement work, particularly so that interventions can be scaled in other settings. Second, we need to commit to learning through evaluation. So again, this is about committing to accumulating learning in a systematic fashion. And the reason for this is about allowing us to make reliable judgments about effectiveness of these initiatives, what's working, what isn't working, and what can be amended in future in order to optimize our improvement approaches. And third, we need to commit to closing this gap between stated policy goals or policy objectives and program design. So in too many areas, we see gaps between policy commitments and how programs are designed. So for example, in commitment to supporting challenge services, so those struggling to improve, and particularly in relation to underserved populations. So I'll close there. Very happy to take any questions and to continue the conversation by email. And thank you very much for the opportunity to present to you.